All right, thank you. My name's Nikolai Begg. Thanks for all coming today. And I want to talk to you a little bit about kind of my story, how I got into this, and what it means for you all, hopefully. But I titled my talk Curiosity, Fascination, and Experience, because really, those are the three things that I think are absolutely critical if you love invention, if you want to be inventing. So hopefully through kind of the story I'm telling, you'll be able to kind of see that. But I'm going to start with 2006. So this is me in 2006. So I grew up playing with Legos. I loved to build things, and somewhere along the way, I really fell in love with the prospect of creating something entirely new. And that's really the prospect of invention, right? But I discovered what I truly loved in English class. We had to write a report on something that fascinated us, and I picked robotic surgery. It turns out that there were robots out there helping surgeons do these really complex, minimally invasive devices. And I just really latched onto that. And I thought, wow, there's engineers out there doing what I love to do, building things, and you could actually be helping people at the same time. You could be making a real impact. So ever since then, I absorbed as much about that field as I could. And when I got to college, I actually sent some emails to local physicians in the area and said, I love what you do. I want to learn more about what you do. And they said, all right, come on in. So I basically spent a summer in the operating room in research labs, learning about surgery, learning about what they did. And it was here that I first learned about laparoscopic surgery. So for those of you who don't know, laparoscopic surgery, instead of creating a large open incision in the abdomen, the surgeon goes in through a couple small incisions. I have a model down here, 10 millimeters or less, sticks some thin instruments through and a camera and does the procedure inside. So instead of this huge scar, this huge incision, which will keep you in the hospital for weeks, you're in the hospital for just a couple days, and there's a lot less pain, a lot less risk of infection. There's just one problem, and there's this instrument here called the trocar. And the trocar, it's what creates that incision for the surgery. And so, first time I saw trocars, this is what I saw. And I don't know what this looks like to you, but to me it looked like something some Spartans should be hurling at their enemies, right? Really not a friendly instrument, not really synonymous with helping people in surgery. And just to demonstrate what inserting a trocar looks like, I saw this for the first time, and I was going, oh my goodness. Basically, it's basically, you're getting the idea here. This isn't apparently not a very sharp one. That's a trocar insertion. Kind of brutal. And I said to myself, what? Why is it being done this way? And I asked the surgeons, why is it being done this way? Because I noticed that this instrument was the one they were paying attention to the most. It was the one they seemed almost the most afraid of. So you guys already understand the problem. Who's drilled into a wall before? Most of you, right? So without punching your neighbor, what happens right when that drill bit pierces the other end of the wall? You kind of jerk forward, right? Okay. Well, now let's consider this is your trocar, and then you have the abdominal wall, and let's say some major blood vessel like the aorta right behind it, okay? Who knows what's going to happen, okay? In some cases, it's lights out. Bad news, okay? And I didn't see this happen, but I saw, this kind of really seemingly kind of, intense part of the surgery, and I said, okay, how big a problem is it really? So I looked around. It turns out the FDA, which is the big government body which does all regulation of medical devices, in 2004 they said, well, these devices are the most dangerous step in laparoscopic surgery. That's a pretty big statement for that government body to make. 2009, and this mirrors other literature you'll find, it's a paper that says over 50% of all the complications in laparoscopic surgery are due to this step, just this step. Not only that, but this rate, this kind of complication rate has been unchanged for 25 years. So think about what computers looked like 25 years ago, okay? It's a pretty big deal that this hasn't changed. Why hasn't it changed? Why can't it be done better? And furthermore, if you do a little math, there's about a 1 in 1,000 risk, which is kind of what's agreed upon, that this is going to happen. Okay, not that it's going to be major, but that the surgeon's going to poke too far. Over 4 million or 5 million now procedures performed in the year, each year in the United States alone. So that's 40,000 complications in this country per year alone. That's a big problem. So why does it happen? So some of you, a bunch of you, I'm sure, have taken physics, but when you start inserting the trocar, The force you're applying to the trocar is balanced by the force that the wall, or the abdominal wall, is putting back on it, right? Balance of forces, so Newton says no acceleration. So you start drilling through, puncturing through tissue, and there's that moment when the tip of the device punctures through tissue, and that resistive force goes away. So for the instant, or for the duration of time that your brain is reacting, you get an unbalanced force, and that causes an acceleration. And that's where the danger comes in. But what if, right when the tip of the device punctures the patient, you could pull the tip back, right at that instant? You'd be actively opposing that forward acceleration and making the whole process a lot safer and less risky. And that's what I set out to do. So I'm going to kind of tell you how the device works and then show you it working. So consider the case, or the handle of the device, and you have the tip. It's a sharp-bladed tip, and you attach it to some sort of spring, right? So when you extend the spring, you're going to get a force that's trying to pull the tip back. That's great. That's what we want. We want it to retract. Now, how do you keep it in place until that moment when it punctures? Well, that's where this linkage comes into play. So I have a really fancy name for this linkage, like a force bias, double knuckle, frictional clutch linkage, but really it's a bunch of links. And basically, when you press the tip of the device against tissue, the linkage expands, and it wedges itself outwards against the wall. So because of friction, now the spring can't retract the tip. So as long as we're trying to push through tissue, as long as we have force applied to the tip of the device, the blade stays exposed. But just when the tip of the device punctures tissue, that opposing force goes away, so the mechanism collapses and retracts the tip upwards. So in case you don't believe me, so here's one of our prototypes, actually puncturing through some, I think it's latex rubber, but basically it's going to be really fast. So you're going to see the blade right at the tip, and then there's also going to be a blunt sheath, which is basically much less risk of injury. The blade is a sharp metallic blade, and this is taken at 500 frames per second, played back at 30, so about 16x slower. But take a look. So right when the tip punctures, you see it pull back all of a sudden, and that's before the tip of the device itself actually starts accelerating forward into the patient. So okay, we have a prototype that works. What's next? Now, I love telling this story to doctors because every single time I tell them a story about this device, they say, why don't you use it here as well? And the thing I've realized is that puncture access, I started working on laparoscopic surgery, but puncture access is everywhere in medicine. Think of the last time you went to the doctor and he didn't stick you with a needle or something, right? It's everywhere. It's across all these different procedures, and the list keeps growing. And a lot of these procedures have the same risks and complications. So if you just take 3 of them, we talked about laparoscopic surgery. Let's also hit epidural anesthesia. That's anesthesia into the spine, and that's a puncture access procedure. A needle has to hit the right space between the spinal cord and the dura. And thoracentesis, where they're actually sticking a needle in between the lung and the chest wall to try to drain fluid from an infection. So these 3 procedures alone account for over 180,000 complications per year in the United States, and over 10 million patients per year in the United States are sharing the risk of such a complication. I call that potential impact. So I'm excited to count the numbers from all these different procedures. But really the challenge right now is figuring out, okay, where to start, right? You have this idea, and what's the best application for it? So I want to kind of just summarize by saying if you love invention, because that's why you're here, right? I want you to be curious. Be curious. If I'd never asked questions of the surgeons I was working with, if I had never said, why are you kind of afraid of that device? How does this work? How could this be done better? I never would have learned all this stuff. I would have just been, okay, watching them do the surgery, and you find these problems. Everybody's talking about invention as a problem-solving exercise. You find these problems by being curious in the first place. Stay fascinated. You might say curiosity, fascination, same thing, but I say that fascination is really, you hear talk about passion or loving what you do, and that's what I call fascination, if you can really be enthralled by something. If I had just emailed these doctors and said, I need some extra credit for science class, your stuff's kind of cool, can I see? They said, no, it's an operating room. What are you talking about? Instead, I came at them with, I love what you do. Fascination, it gives you conviction. It convinces people of your ideas. It convinces people that you're going to spend time learning about what they do. And that's why I've had these opportunities that I've had. And lastly, live the problem. And by that, I don't mean, go and fall over a trocar a couple times, right? I mean, you want to watch the problem in action, okay? An operating room, it's not like you think. It's not like an ER. Everybody's not just staring the whole time and everybody's freaking out. People are playing, rock and roll in the background and talking about the Bruins. Sorry about last night. But like they're at work. But then there's these moments when the music stops and when they all stare at the same thing. And that's when you pull out your notebook, because that's when something really important is going on. And you have to be there. You have to be living in the environment to see that. So I'm really happy Eduardo talked about crappy prototypes, because this was my first crappy prototype. I built this in about 20 minutes. Yes, those are popsicle sticks, but it worked. It worked, and it justified the next 2.5 years of work on this project. So always build it quickly. Try to hold it in your hands, because really that's what's going to tell you, does it work? Is it worth it? What can you learn about it? And of course, I have to thank a lot of people. I want to thank the Lemelson-MIT program, Dolly Lemelson, and the Lemelson Foundation. My advisor, Alex, who let me tinker on this for about 2 years. Ernesto Blanco, who's a brilliant inventor and my first mentor at MIT. And then Dr. Wen, who when I said, as a freshman in high school, can I come and stand in an operating room? Said, yeah, come on in. Everyone else who helped on this project, and of course my family as well. So thank you so much. I'm happy to take questions.
So Nikolai, are you more interested, say, in starting a company and a medical device company, or in licensing this device?
It's a good question. So medical devices, it's an interesting space because it takes a lot to get a medical device from your desk, from the prototype phase, into a patient. Because that wonderful government body I was talking about, the FDA, makes it really difficult for a good reason. So really right now, it's because there's so many different applications, I think I'm going towards seeing different players in that space and saying, try this out, do you want to use this? But if they don't bite, I'm going to do it myself.
Maybe I missed this, but what did you major in?
Oh, sorry. Good question. I'm earning my PhD in mechanical engineering.
My question is, have you ever put a micro camera in the front to see your drill where you're heading to?
Sorry? I'm sorry, I didn't.
Have you ever put a micro camera in the front of
putting, okay,
device,
a micro camera, yeah. So it's interesting, they do have some Trocars, actually, here's one. So this Trocar is designed with a plastic tip, and it's clear so that you can actually stick that camera down the middle of it. And the idea is that as you're going through tissue layers, you can kind of see where you are. Problem is it doesn't work. At least surgeons don't say it work, which is the important one. And the other thing is I tried to make this device purely mechanical. So actually, if you come to the showcase, I'll have it with me. It only has 5 parts. And it's an entirely mechanical device. And one thing that the medical device world right now is really focusing on is maybe not cost, but value, and trying to get these devices a lot cheaper. But it's always a possibility. Thank you. Thank you so much.